All webinars have closed captioning function available, and you can find the closed captioning function in Zoom at the bottom of your screen in the kind of the more option if you're not seeing it automatically come up. So if you've been to an I-STARR webinar before, you'll know that the I-STARR project is supported by a grant from the National Institute on Drug Abuse and is part of the larger NIH Helping to End Addiction initiative, or the HEAL initiative. And it's also one of several projects that comprise the Consortium on Addiction Recovery Science, or the COARS network. Let's go to the next slide. So for folks who don't know me, I'm Dr. Amy Miracle. I'm a research scientist in the Alcohol Research Group at the Public Health Institute. I co-lead the I-STARR project with Dr. Carmen Masson, who's a professor of psychiatry in the School of Medicine at the University of California, San Francisco, and who you'll be hearing from today. So the team also includes co-investigators Sarah Zemore and Lenny Jason, biostatisticians Mina Subbaraman and Lebo Lee, communications specialists Diane Schmidt and Dustin Kebzu, and the team's project coordinator is Quinoja Capitani. Let's go to the next slide. So the I-STARR project also has an amazing advisory board. We have 17 advisory board members comprised of a diverse group of leaders from across the country. So our advisory board members represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, as well as researchers and educators. Let's go to the next slide. So let me tell you about our speaker today, Dr. Carmen Masson. She's the fearless co-leader of the I-STARR project, but as noted earlier, she's also a professor in the Department of Psychiatry at the University of California, San Francisco. So her research focuses on understanding and addressing barriers to health promotion and health access among individuals who use drugs. So using principles of community-based participatory research, she's conducted studies of individual and system levels, behavioral interventions to improve access to and delivery of substance use disorder treatment, harm reduction services, and hepatitis C healthcare services. So these studies have been important in identifying effective strategies to link people who use drugs to HIV and Hep C education and prevention interventions, opioid substitution therapy, and Hep C evaluation and treatment. So Dr. Carmen Masson has also had a long-standing commitment to training and development of early-stage investigators, and has mentored undergraduate students, postdoctoral scholars, and assistant professors. I feel lucky to be included in the many postdoctoral scholars who've gotten to train with Dr. Masson. Currently, she's the director of the NIDA-funded Learning for Early Careers in Addiction and Diversity, or what goes by the LEAD program at UCSF. And that is a research training program that supports the career advancement of clinical scholars from underrepresented racial and ethnic groups working in the addictions field. And so without further ado, I want to turn things over to my colleague, Dr. Carmen Masson, to talk about recovery housing for marginally housed populations.
Thank you, Amy. Thank you, everybody. So Amy gave me such a nice introduction, and I'm happy to be here with all of you. So I'm Carmen Masson, and the topic of today's presentation is recovery housing to support marginally housed and people experiencing homelessness with opioid use disorder. Next slide, please. So what the goals of today's presentation are to describe opioid overdose death risks for marginally housed and people experiencing homelessness, also to identify unique recovery challenges facing people experiencing homelessness. Through a study that we conducted here in San Francisco, we will describe the correlates or associations of treatment with sublingual buprenorphine among people experiencing homelessness. And also we're going to discuss recovery housing's role in supporting those who are marginally housed or people experiencing homelessness. Next slide, please. So we're going to focus first on opioid overdose deaths in the United States. Next slide, please. The opioid epidemic has had devastating consequences or impact in the United States, as many of us know. We've been living through this for several years. Opioid overdose deaths have become the leading cause of death in the United States. So this slide shows drug overdose deaths in the United States from 2015 through 2024, which is the latest available data. As the pandemic began to ease, we've seen overdose deaths started to decline over the past year or so. So drug overdose deaths peaked in August of 2023 with over 111,000 deaths, and it started to decline thereafter to 82,000 deaths as of October of 2024. But overdose deaths are still high, and they're as high as they were during the start of the COVID pandemic. And approximately, as demonstrated in this brown line here, 90% of the overdose deaths are attributed to the use of synthetic opiates or opioids, fentanyl, carfentanil, for example. Next slide, please. So this slide shows overdose deaths overall, and this is represented in the dark blue bars for each quarter from 2021 through 2024, and the percentage of overdose deaths with illegally manufactured fentanyls, which are the light blue bars. And as you can see, over the period of January 2021 through June 2024, approximately 70 to 80% of the overdose deaths in the United States were estimated to involve illegally manufactured fentanyls. Fentanyl is a very potent, inexpensive drug that has devastating consequences for public health. Next slide, please. Now, in San Francisco, when we look at accidental overdose deaths by drug class, we've seen a steady increase also in opioid-related deaths in San Francisco since 2017. And as you can see in this slide, of the 810 accidental overdose deaths in San Francisco in 2023, 656 involved fentanyl, or that is 81% of the deaths involved fentanyl. Next slide, please. Now, this slide shows accidental overdose deaths in 2023 and their demographics. So of the 810 accidental overdose deaths in 2023, the groups that were overrepresented were males, people who are African American, and people with no fixed address. Next slide, please. So we're going to discuss next some of the recovery challenges for people experiencing homelessness. Next slide, please. So there is a high prevalence of substance use and polysubstance use, mental health issues, and other factors that place people who are experiencing homelessness at very high risk for fatal and non-fatal overdoses. As a result, drug overdose death is the leading cause of death among people experiencing homelessness. People experiencing homelessness are also less likely to receive medications for opioid use disorder as part of the treatment plan, as compared to those who are not homeless, and may often receive detoxification services and inpatient care and not kind of long-term recovery care. So there's more research that is needed to better understand what are the challenges and resources or facilitators that may help people who are marginally housed or homeless receive treatment for their opioid use disorder. And there's really an important population that we need to focus on because they're at especially high risk of overdose death. Next slide, please. So we know, many of us who are working in this field, that the U.S. Food and Drug Administration has approved several medications for the treatment of opioid use disorder. And these include methadone, buprenorphine, and naltrexone. So the focus of our presentation today will be on buprenorphine, because this is the medication that I study. It is understudied among people experiencing homelessness. And then there's a new extended release injectable formulation that we know little about among the homeless population. And that's what kind of spurred my interest and why I've pursued this area of research. So what is buprenorphine? It's an FDA-approved medication to treat opioid use disorder. It's a partial opioid agonist. It reduces cravings, withdrawal symptoms, and the risk of relapse. It comes as sublingual or buccal tablets, films, and also as an injectable extended release formulation, which is administered once per month. And this new injectable extended release formulation may especially benefit people who are experiencing homelessness, who are unable to store medications, right? Or have difficulty adhering to a daily medication regimen. So that's the benefit of having this kind of once monthly injectable medication. Next slide, please. But although buprenorphine is effective for the treatment of opioid use disorder, most people who need this treatment do not receive it. And there are multiple factors, interconnected factors at the patient, provider, and system levels that contribute to underutilization of buprenorphine. Specifically, the stigma related to using or prescribing medications for opioid use disorder. And I hear it from, physicians and pharmacists who feel that pressure. Treatment experiences and beliefs about the medications, negative experience with buprenorphine, such as precipitated withdrawal from concurrent use of opioids or non-prescribed buprenorphine use, has been cited as a barrier to starting buprenorphine treatment. There are also logistical issues with distance, time, the costs of the medication, lack of insurance, regulations surrounding the medication itself and how they can be prescribed or where they can be dispensed. There's a lack of knowledge about opioid use disorder and the role of this medication, both among providers and patients themselves. There are also social determinants of health, such as homelessness and the lack of stable housing that disrupts someone's stability, their access to care, and also their ability to adhere to treatment plans. Next slide, please. So the ongoing opioid crisis, particularly the rise in fentanyl-related overdoses, has contributed to more people seeking treatment for opioid use disorder, but we just don't have enough treatment slots for people who need it. As a result, many individuals prescribed medications for opioid use disorder, such as buprenorphine, need housing options that support their treatment and recovery. Recovery residences can play a key role in meeting this need, the growing need for supportive housing, and addressing the opioid epidemic in the U.S. However, there are several barriers to the use of medications for opioid use disorder, such as buprenorphine, in recovery residences. And we have a number of excellent investigators here who are dedicated their lives to studying these issues. And what they found is that stigma regarding medications for treatment of opioid use disorder in recovery residences, both from the residents themselves and the recovery housing operators. There may be concerns about risk for diversion and concerns about resident safety with these medications. There is a lack of knowledge and understanding about medications for opioid use disorder, their efficacy, and their importance in treating opioid addiction among recovery housing operators. And there's a lack of resources to monitor medication adherence, challenges with medication management in these settings. And also there may be a preference still for abstinence-based approaches in these settings. Next slide, please. So through, as Amy said, I've been really very interested in trying to improve access to care and the delivery care for vulnerable populations. And this led to a study that we conducted in San Francisco to try to identify what are the barriers and what are the facilitators to accessing buprenorphine treatment among people who are homeless. Next slide, please. So what we did was to conduct a cross-sectional survey. And the survey was conducted between April of 2022 and August of 2023. We surveyed homeless adults with opioid use disorder who were recruited from harm reduction programs in San Francisco. For this particular study, we focused primarily in the Tenderloin district. So the majority of our participants were recruited in that area. Next slide, please. For those of you who are familiar with San Francisco. With respect to the inclusion and exclusion criteria, to be enrolled in this study, you had to be at least 18 years of age. You should be currently homeless or marginally housed. You should have an opioid use disorder as determined by the DSM-5 opioid use disorder checklist. And those who were not able to provide informed consent, because we were recruiting people who are actively using substances, they needed to demonstrate the ability to give informed consent. Those who were currently receiving pharmacotherapies for opioid use disorder, such as methadone, buprenorphine, naltrexone, were excluded from participation. People who were undergoing counseling or another behavioral intervention for opioid use disorder were also excluded. Next slide, please. So this was, I would say, one of the most challenging studies that I've had to conduct, just because of the population, working with such a vulnerable population, who were essentially living on the streets or the lack of resources and who are actively using substances. So even, how we approached people on the street to invite them for the interview was pretty challenging. So we approached them as they were heading in to get syringe access supplies. So they were getting new syringes, they were getting other supplies for using substances. So we approached them after they had done the syringe exchange service, and we engaged them in a brief eligibility screening, about 5 minutes. If they were eligible, then we completed an informed consent process. We administered an hour-long survey with them, and then we also compensated them $35 in cash for their time and effort. Next slide, please. So we looked at a number of variables or measures that we know are associated with service use, particularly in the substance use disorder field. We were really interested in knowing how each of these variables or each of these measures were correlated or associated with the outcome of whether or not people had a history of being prescribed sublingual buprenorphine. So with respect to health status, we use the CDC's general health question. What would you say your general health is in the scale range from excellent to poor? We assessed the mental health status using the modified Colorado Symptom Index. And if you're not familiar with that, it's a instrument that assesses psychiatric symptoms over the past 30 days. We looked at health literacy, so the participants' ability to understand medical information. And one of the sample items I have here is, how confident are you filling out forms by yourself? And it was also a 5-point Likert scale from always to never. We use the Addiction Severity Index, the drug and alcohol use sections, to look at past 30-day substance use and lifetime substance use. And then we developed 2 scales, the perceived service barriers for sublingual buprenorphine and also perceived service facilitators for sublingual buprenorphine. And so this, I think it's over 20 items for each of these scales, and we have a total score for the scale, and people respond yes or no to those items. We also looked at a published instrument that examines attitudes towards sublingual buprenorphine, and it asks people how, I guess, accepting they are of buprenorphine, or their perceptions toward its effectiveness, or how helpful it would be in their lives. And this is a 5-point Likert scale that ranges from strongly disagree to strongly agree. And then we were also interested in, like, how motivated might people be to address their substance use, and could that influence whether or not they get prescribed sublingual buprenorphine. And so we looked at 2 items, readiness for change items, and these are often used in other studies and clinical trials. And the question is, how important is it for you to cut back or stop using opioids? Next slide, please. So here are some sample items. So examples of questions that we developed, and this scale was actually informed by interviews that we held with service providers. So we interviewed nurses, prescribers who were physicians, pharmacists, harm reduction specialists, harm reduction educators, counselors, about what they perceived were the challenges for people accessing buprenorphine, either starting buprenorphine or being maintained on buprenorphine. And so those interviews really informed the questions that we developed, that we created with our research team. We also looked at the literature to see what had been found in the past about what these challenges are for people with respect to sublingual buprenorphine. So some example questions are, I don't have a patient navigator who can coordinate my buprenorphine treatment. So they have to respond yes or no. The cost of buprenorphine treatment is too high for me. I'm worried about going through withdrawal to start buprenorphine treatment without having access to a bathroom. I don't have a safe place to store my buprenorphine medication. I have too many other problems to worry about. My mental health issues get in the way. Right now, I'm not interested in buprenorphine treatment. Next slide, please. So here are the perceived facilitators for sublingual buprenorphine. So we asked them, how likely would it be for you to start buprenorphine treatment? And again, this was like a 5-point scale from very likely to very unlikely. How willing would you be to start if, for example, if permanent housing were offered along with buprenorphine? If I did not have to go through opioid withdrawal first? If buprenorphine was delivered to me where I live? If buprenorphine treatment were offered in mobile vans? If I knew buprenorphine treatment worked for people who are using fentanyl? If a community agency could store my buprenorphine safely? And if I knew more about buprenorphine treatment, including about side effects? Next slide, please. So our dependent variable, and what we wanted to know is, what proportion of this sample is actually receiving or had received prescribed sublingual buprenorphine, and can we predict who the individuals might be, or what characteristics of these individuals might predict whether or not they had ever been prescribed this medication in the past. So the question we asked participants was, have you ever taken any of the following medications through a program or by prescription? And we asked specifically about buprenorphine, both the sublingual and extended release formulation. We asked about methadone. We asked about naltrexone as well. Next slide, please. So going to review with you some of the study results. Next slide, please. So we recruited 310 participants. The average age of our participants was 37. The majority of our sample were males. Next slide, please. With respect to race, ethnicity, the majority of our sample was white. and fewer were from other racial ethnic minoritized groups. Next slide, please. The majority of the sample had at least a high school education. They were unemployed, but they were enrolled in Medi-Cal or Medicare. 77% to be exact. Next slide, please. So with respect to where they were living, the majority were unsheltered. They were either living in a car or on the street and were homeless, and the majority were homeless for over a year. Next slide, please. With regard to their psychiatric status and health status, we find that over half had fair to poor health. And with respect to health literacy, the health literacy score was 10.3, almost 10.4, would suggest that they have moderate to high health literacy, with most being fairly confident in their understanding and using health information, though not necessarily confident in all areas. And then the sample also scored a 29.7 on the Colorado Symptom Index, indicating high psychiatric severity. So a cutoff score of 24 suggests high psychiatric symptomatology. Next slide, please. So this is past 30-day drug use. And what we can see from this slide is that almost 93% of this sample used fentanyl. Any stimulant, almost 97% used any stimulant. Next slide, please. We also looked at drugs in combination with fentanyl, because this is very common. And we found that in this sample, about 83% had used methamphetamine and fentanyl, and 90% fentanyl and any other stimulant. Next slide, please. So this slide shows the route of fentanyl use. As you can see, it's interesting that 45% are injecting fentanyl, and about a similar amount, 45%, are inhaling it. And in recent years, there has been more of a shift, right, because of the harms caused by injection drug use, the risk for infectious diseases, to more smoking, inhaling drugs. But it's interesting to see that you have half and half. So we think that our public health messages, have penetrated this population, but it's still interesting to see that a sizable number are still injecting fentanyl. Next slide, please. So with regard to the history of prescribed sublingual buprenorphine, we find that the majority have had experience with sublingual buprenorphine. They had used it in the past and have been prescribed it, and fewer had been prescribed the extended release injectable buprenorphine. Next slide, please. So this is our logistic regression analysis. And, I described several of those variables that we were interested to see how they were related to the outcome of whether or not people actually had been prescribed sublingual buprenorphine. So we looked at health status. We compared people who had good health to poor health, mental health status, their health literacy, whether they were daily fentanyl users. So people who are using fentanyl every day versus people who are not, or not using fentanyl at all. We looked at our two scales of barriers and facilitators to sublingual buprenorphine with a total score. We also looked at their attitudes toward sublingual buprenorphine, and then whether they felt it was important to stop or cut down on opioid use. And the outcome is, we're trying to predict, have they had this history of prescribed buprenorphine use. So we used a model building approach. We had separate simple logistic regression models that we looked at the relationship between the independent and the dependent variable. We tried to rule out demographic variables, diagnostic variables, and then we ran a multivariable logistic regression model where we looked at those independent variables that were significant in those simple logistic regression models, and then we combined all those variables in a multiple variable logistic regression analysis. Next slide, please. All right, so when we looked at these simple logistic regressions and the history of prescribed sublingual buprenorphine, we find that daily fentanyl use and having more positive attitudes towards sublingual buprenorphine were associated with a higher likelihood of being prescribed, right, sublingual buprenorphine. In contrast, we found a negative association between barriers to the use of sublingual buprenorphine and the history of being prescribed buprenorphine. Buprenorphine. So suggesting that as barriers to buprenorphine increase, people are less likely to have been prescribed sublingual buprenorphine. We also found that people who identified as white, that white individuals had a 1.8 times higher odds of having been prescribed buprenorphine compared to individuals of other racial or ethnic groups. Next slide, please. So here are the results of the logistic regression model. And so we want to see what are the independent predictors of this history of being prescribed sublingual buprenorphine. And the results, the analysis, we controlled for age, gender, race, education, and we found still these same variables remain significant in this multivariable logistic regression model. We find that suggesting that daily fentanyl use, more positive attitudes toward buprenorphine, having fewer perceived barriers to its use, and being white were significant factors that increase the likelihood that someone or this sample of people who are homeless would have been prescribed buprenorphine. So after accounting for all of these variables in this model. Next slide, please. So in conclusion, what did we find? Fentanyl use was highly prevalent in this population. 93% had used fentanyl in the past 30 days. Fentanyl use in combination with any stimulant was also highly prevalent. Over 2/3 had a history of prescribed sublingual buprenorphine, which is encouraging. In our multiple logistic regression model, showed that people who were experiencing homelessness and who are more likely to have been prescribed buprenorphine were daily fentanyl users, had higher positive attitudes toward buprenorphine, had fewer perceived barriers to its use, and white individuals as compared to individuals of other racial and ethnic backgrounds were more likely to have been prescribed it. So, we believe that recovery residences do present an excellent opportunity to expand access to buprenorphine for people experiencing homelessness. So expanding the access of both buprenorphine and these parallel efforts to improve access to safe housing, such as recovery residences, should be a priority for our policymakers and also our treatment providers. But as you see in our discussion earlier, there are a lot of barriers to integrating medications for opioid use disorder, including buprenorphine, and recovery residences. Thank you. So that part of the presentation is over. So I guess we have some time for questions. I hope I didn't speed through that. I know
that was fabulous, Carmen. Just an amazing study. Yeah, very rich. Congratulations. I know this was a smaller scale study, but I didn't realize that you had recruited 310 participants into the study. So congratulations on that. That was quite a feat, I'm sure. So yeah, we're open for discussion now, folks. Some people have dropped things into the chat already, and we can start there. But also, please feel free to unmute yourself and ask a question. You can raise your hand within Zoom, and we can call on you. But we do have an opportunity to learn from Carmen about this population, about her study, and it's really timely to think about recovery recovery housing for the marginally housed and underserved population that she has expertise in. I mean, you would think that, recovery housing and the homeless population would be a natural fit. But I think that there's underutilization of recovery housing by this population. I guess one question for you, Carmen, is for your study, how are you defining homelessness? Because I also think that there are folks who are serving the homeless population in recovery housing. And maybe if we had a better way to measure this, how who they're qualifying as homelessness or homeless or marginally housed, and how would they capture that information?
Yes, I think we did use the federal definition for homelessness, which I don't have right in front of me, but we, so people who did not have a residence, people who were marginally housed, who were living with friends or relatives, but it was not a permanent situation that they could lose housing right away. But we did use the federal definition for homelessness. Yeah. And I can't recall what it is, so I'm sorry.
So scrolling through the chat, we had one question early on from, I think it was about recovery housing and installing panic buttons in residents' bedrooms to increase response to overdose times. That's probably not something that you covered in your study, Carmen, but I'm wondering if anyone in the audience has anything
I am familiar with it though, Amy.
Okay. Oh, lovely.
I forgot what they're called. There's a specific name. There's a company who installs these. Something button, but yes. So, that individuals who are living in kind of supportive housing, that this could be actually a really important way for the staff who are working in these settings to respond to overdoses. So there have been studies on it, or an evaluation of this, sort of looking at how acceptable it was to residents living in that setting, training of actual kind of peers and people who are working in that setting to actually respond to those buttons and monitoring. So they can be effective in identifying overdoses. And often if people are living in these single room hotels and other places where they're alone, that's where you have and they're actively using, that's where you have a very high risk, right, of overdose death, because there isn't somebody there who can administer Narcan or support them or call 911. So they are an acceptable and effective way of alerting staff to emergencies like this.
And wow, I'm not familiar of any research on that happening in the recovery housing sphere of things. So that might be an interesting thing to study if we have any young investigators or new investigators, early stage investigators on the call. Other questions? So we have a question from Dr. Springle. Do you want to unmute yourself, or would you like me to read your question?
Here it is, yeah. Ronald, is that what you're saying? Ronald Springle?
Yes, Dr.
Hi, Ronald. Nice to meet you.
Love your presentation. Thank you so much. Very valuable research.
Oh, do you want to read your question or your statement?
I can just restate it. So we have some limited data from 2023. This is from EMS data, medical examiner data, and the Suter system, which a lot of states used for surveillance. And it's not all public, but we can glean from that we can calculate there was a 6-fold chance of dying in an uncertified recovery residence versus one certified at the national standard by NAR, which in Maine is MAR, the Maine Association. And it's the only pearl of data of this type that we've come across. And I'm just curious with your national perspective, and also for Amy and Jen Miles and the others on the call, if they come across anything like that indicates that the margin of fatalities is so much greater in uncertified residences.
Wow, that's incredible. That's just incredible. So, I mean, that just, further evidence for the need of staff training, education, and increasing the standards, right, for those recovery housing settings. Amy and Jen Miles and other people who are experts here, please chime in.
We also have Dr.
Lenny.
Lenny Jason on the call as
Lenny,
well.
yeah.
I'm not familiar of any of that kind of research, Ron, so we should definitely talk more about what you've done in your settings to try and suss that out, because that would be a very important indicator, just as Carmen said, about the importance of training, standards, certification, all of those pieces. Lenny, do you want to chime in? You also had a question in the chat.
Yeah, I just think that's a really important question that's raised, and it just shows you how little we know about this field and why there's so much importance to do this type basic research to find answers to exactly what you asked. The question I kind of raised as I was listening to this, Carmen, I was wondering, of those hundreds of people that had possibly a serious mental health challenge, maybe even a psychotic disorder, is it possible that if they were appropriately medicated and supervised, that they could potentially be in recovery homes with MOUDs or just in those types of settings that are even kind of more independent living? So I'm just kind of wondering, is it possible that some of these folks who are on the streets, homeless, could actually be brought into the recovery homes with severe mental disorders if they were appropriately managed?
Yeah, Lenny, I think I think it would need to be a specialized recovery home, just because the length of time that individuals have been homeless, the high psychiatric symptomatology, which is the result of the fentanyl use. There's a lot of, for some of these individuals, it may be persistent psychotic symptoms, right? So they would need to be medicated and maybe medicated for the rest of their lives. So I think it would have to be a very specialized recovery setting for people with co-occurring mental illness and substance use disorders. Yeah, but I think it would be a great idea. Oh, Diane and Christine.
Yeah, we have people with their hands up.
ahead.
Diane, do you want to ask a question?
Yeah, I'm just really curious, Carmen. Originally I'm from Vancouver in Canada, and we have safe injection sites there. And I just wondered, in your research, because I understand that San Francisco, did they have a temporary safe injection site? And I'm just wondering if your research crosses over into any of the work that's been done on safe injection sites, in particular, some of the policies that were going to be passed in San Francisco and never did pass. Just curious about that.
Right. So we haven't done any work at safe injection sites, nor did we. I don't know if they were open for very long. I think they tried it for a very short period of time and then it closed down. It wasn't as successful as Vancouver, right? I think they have active sites and it's supported by the government or public health. So we don't have that here. So we haven't had any experience, with those sites. Ours were mostly harm reduction centers that were operated by the San Francisco AIDS Foundation. So the 6th Street site where people can come in, get fresh supplies, Narcan, and testing. I think testing for Hep C as well.
Okay, and I assume like some needle exchange possibly there too?
Syringe access,
Okay.
yes. Needle
Perfect.
exchange. Exactly.
Thanks, Carmen. Great presentation.
Oh, thank you.
So Dr. Christine North, you have your hand up.
Yeah, Dr. Masan, thank you. This was really fascinating information. I wanted to comment, we are an unusual program here in Oklahoma City where we do 9 to 12 months with individuals. Almost all of my residents are coming from an unhoused population. I have a handful that are not, but most of them are. And when they come in, they are often coming in unmedicated because either their medications have been stolen or they've not been able to manage their medications well. We get them set up with mental health care. We get them to their appropriate clinics. I've got a number of folks who are on both buprenorphine and methadone here. We are very supportive of doing that. And what we discover is that among our residents, the vast majority of them, once they get their mental health meds regulated and once they start working with their MOUD medications, are able to get to a point where they're able to secure work and finally be able to move into regular sober living or other kinds of supportive housing. And I mean, it's anecdotal, but we're the kind of a place where, you know, some of that data could be collected. And it would appear that, yes, a longer term program, it does take us a bit, but we do get them to that point.
That's wonderful, and congratulations on those great outcomes. So important, you know, what the service that you're providing and the help to people. And I think the majority of people there was a recent study that I read that were homeless, were actually using substances before they came homeless. So you see kind of this spiral down, right? But there was about a quarter or a little more who actually started using substances after they became homeless. So, you know, I think that, you know, both groups, you know, could definitely benefit from the services that you're providing. And, you know, the article stressed, you know, the need for longer term care because a lot of these individuals were just getting, you know, short-term detox services.
So we had a comment in the chat from Dr. Jennifer Miles. Jen, do you want to ask a question or reinforce your comment?
Hi, everyone. What a great presentation, Carmen, and so grateful for the discussion. And I think my comment was kind of as Ron, as you were talking about what findings you have in Maine, and that's really fantastic. I wish more states and places were collecting such rich data. But I do think in general, there's lots of opportunity for research in the recovery housing space where we actually start having comparative study designs so we can actually start asking questions around, you know, what are the aspects of recovery housing that might be associated with improved outcomes for people, better outcomes, that we can start thinking in terms of quality measures or, you know, kind of applying some of these health services concepts to the recovery housing space that we know in the healthcare industry more broadly, you know, are there because they're trying to bend things in a direction of improving outcomes for patients. So thank you so much for mentioning that, and always happy to follow up with you and others to start thinking about what potential studies we could submit that would focus on questions like that.
Mm-hmm. And I wanted to say in the citations, I include Jennifer Miles's paper looking at Medicare recipients and a use of buprenorphine, which is consistent with our findings that people from minoritized groups are less likely to be prescribed buprenorphine.
Yes, and a replication of that in the Medicaid population will be forthcoming, and a replication of that in the commercially insured population will be coming. And so it's not just publicly insured folks, it's really everybody that we're seeing, and it's kind of baked into kind of how services are made available to people. So it's not exactly an easy fix, but it is at least a starting point to understand how and who that's affected by that.
Mm-hmm.
We have a question from Niles.
Thanks so much, Amy. Yes. Dr. Masson, thanks so much for an amazing presentation. I wanted to pick up this conversation. Dr. Miles, thanks so much for your work. I really appreciate your contributions. Your work is all over my dissertation. I've been also thinking about how we can increase or improve the approach taking a page out of behavioral science and health services research and maybe increasing the rigor of treatment and understanding of our approaches in recovery residences. But, you know, one hesitation I have, or one open question for me is there potential sort of disagreement, or is there opportunity for or a potential that our approaches could conflict with the peer recovery support approaches? So what I'm thinking is recovery residences rely on peer-to-peer learning and do have kind of some kind of special sauce where folks are helping one another, and which is organic and I think heavily inspired by or drawn from the 12-step movement, which really hasn't involved a lot of this health services research approach or a positivist kind of program improvement approach. And I think we should be thinking ways to increase the rigor and to ask better questions and improve services and that kind of thing. But does that come into conflict with the attitudes and natural approaches within peer recovery support services? That's an open question for anybody.
Yeah, and that's a great question. I'm glad that we have a good mix of recovery housing researchers and providers on this call to start thinking about that. Anyone want to take that?
I'll just respond by saying thank you so much for such a thoughtful question. And I do see, you know, where there's always this push and pull between a social model and a medical model that especially is salient in the recovery housing space and peer recovery space more broadly. So I think that's something that is definitely on my mind, on the minds of most people on this call, probably. In my own dissertation, I included the social model philosophy scale to try to actually measure the extent to which programs that were actually licensed residential treatment adjacent programs, so kind of higher on that medical model than your typical sober home or Oxford House might be. Those are still applied even in those settings, maybe not to the full extent if you go kind of up and down the continuum of recovery housing. So they're not mutually exclusive. But I do think there's important knowledge to be gained in what's in that secret sauce or special sauce that can be applied in lots of different settings, not just in particular, subsets of recovery housing. But thank you so much. What a great question, and great to be thinking and pushing on.
And I think a great opportunity for us to engage recovery residents themselves in shaping our consciousness on what we should be studying, what we need to prioritize, whose voices need to be heard, and that kind of thing, when we kind of bring our approach to improving services.
Great point. So I, unfortunately, am always in the unenviable position of breaking off discussion so that we can wrap things up and tell you what's happening next in the I-STARR project. But before I do, I just want to thank Carmen and thank all the folks who attended today for just an amazing discussion on a very important topic. Let's pull up the slides, Dustin, just so we can give people a heads up of what's coming down the road with the I-STARR project. So we have a webinar again next month. So next month's webinar will focus on, we'll feature two of our advisory board members. So Dave Sheridan and Mark Greeno, who are both key leaders in the fields of recovery housing and the treatment of opioid dependence. And they'll be presenting on kind of emerging issues in both of those fields, specifically changes in to 42 CFR Part 8. So that's happening in April. In May, we'll hear from another advisory board member, Dr. Sharon Reith, and she'll be presenting on recovery housing's place in health services research. Hope that you can come back here again in both in March or April and May. We're in March already. So unless otherwise noted, the I-STAR webinars are the third Tuesday of the month from 11 to 12, and that's for folks on the West Coast, which is from 2 to 3 for folks on the East Coast. And you can register for any and all webinars that we have scheduled on the I-STAR website. You can also stay connected with I-STAR through our social media accounts, which you see listed on this slide. And you may notice that we added a new social media account, Blue Sky, and we're also in the process of developing a LinkedIn account. So if you go to the I-STAR website, you may also see information about the I-STAR training series. So the I-STAR training series is separate from the webinar series, which is live and once a month. The training series consists of 12 webinars with separate training topics for recovery housing operators and providers, as well as those who are interested in conducting research on recovery residences. And folks who participate in all 12 webinars in the training series will receive a certificate of completion and also be provided with the option of being identified on the I-STAR website as someone who's completed the training series. So moreover, up until the end of April, the end of next month, those who complete the Recovery Housing Operator Provider Training Series, again, those who view all 12 webinars, can submit their attendance sheet to NADAC to receive 12 CEU credits for completing the course. So at this point, because the live training series has ended, we can only track participation if you view the webinars on our learning management system, which is housed on the I-STAR website. So if you're interested in, again, completing that training series, if you're an operator provider or a researcher and you have any problems accessing it, feel free to reach out to us. We want to make sure that folks who are interested in participating in the webinar series or in the training series can have access to it. Let's go to the next slide. So the last thing I want to alert folks to is to the NCARS conference. At the outset, I mentioned that I-STAR is part of COARS, which is the Consortium on Addiction Recovery Science, and they host the NCARS webinar or the NCARS conference, and that's the National Conference on Addiction Recovery Science. It's a virtual conference, and it will take place in next month, April 23rd through the 24th. And even though early bird registration has passed, registration is still open. So if you're interested in participating in the NCARS conference, there's still time to get connected and to register. I'm on the planning committee for the conference, so I'm a little bit biased, but I think that this year is going to be even better than last year. We've added a couple things, like an opportunity for kind of newer or folks who are newer to the field, early stage investigators, recovery scientists, opportunities to get mentoring from folks who have been in the field for longer doing research on recovery housing. So that's a new piece. And we also added a new piece on involving folks who are advocates and leaders in the field space to have virtual booths to interface with recovery housing researchers in that method. So we hope that folks will be curious and attend the NCARS conference. And again, it's April 23rd through the 24th. And we already dropped into the chat information about how you can get connected with the NCARS conference. So we are at the top of the hour. We can go to the next slide. And again, I thank you, Carmen, an amazing presentation, an important topic. Thank you for all the folks who showed up today and participated in the discussion. It was a really good and really robust conversation about this topic. And we hope that we'll see everyone back here next month for the I-STAR webinar series. So have a wonderful rest of your afternoon.
Thank you, everybody, for being here.
Thank you so much.
Bye.